My name's Jestin Carlson, and I want to talk a little bit today on sepsis. We're going to look at it through the lens of a couple of cases, and these are actual cases that came to litigation, and use those to help us better understand some nuances of how we can better identify subtle cases of sepsis and also take better care of the patients that we are seeing in the emergency department. We're going to look at a couple of things that might not be right on the topics that we traditionally think of with sepsis, but that's where using the cases that we're going to look at, we'll be able to identify a few different things that hopefully will help to change your practice, and again, help us take better care of the patients we see in the emergency department. I have no relationships or any commercial interests for this talk, but I do want to put right up front the three things that I hope you'll take away from this. First is to fear discharge tachycardia. I'll talk a little bit about what the fear mnemonic stands for and how we can use that to take better care of patients with some actual cases. The second is to not routinely perform abdominal x-rays in patients who present with abdominal pain. There are lots of limitations around that, and we'll talk through that with an actual example based on several other cases as well. The last has to do with kidney stones and the rule of 10 with those and how we can use those moving forward to take better care of patients that we see with potentially infected kidney stones. So let's start with an actual case. Now, the cases that I'm going to cover in the next few slides and with each of these topics are real cases that went to litigation, and while there were many allegations in the actual cases themselves, I'm going to highlight a few elements to really pull out some things that might change your practice and certainly change my practice as I've gone through these and learned from these cases. The first one is a 21-year-old female who presented with back pain. Now, this lady came in complaining of severe back pain, 10 out of 10 back pain, right in the lower lumbar area. And let's look at a couple of things with her. So her vital signs are here on top. Blood pressure 111/58, temperature 99.4, not a fever, but getting close to that. Her heart rate's 116, so she's certainly tachycardic with this. Respiratory rate of 18, and her O2 saturation is 96% on room air. Again, her pain is severe. She has 10 out of 10 back pain. It's really localized in the lumbar region. Now, from a history standpoint, she does have a history of IV drug abuse. In her story, she tells the clinician, yes, it's in my lower back. It's been there for about 2 to 3 days, but has no other symptoms with it. She's tried over-the-counter medication. She's tried ibuprofen and things like that, really without relief, but doesn't have other symptoms. She has no urinary symptoms. She has no saddle anesthesia. She has no paresthesias, no numbness, weakness, tingling, loss of sensation, any of those other symptoms. Just severe back pain in the lower back. Now, in her workup, she does get several tests done, including a urinalysis, WBC, complete blood count. She also gets an ESR, and some of those are listed here. Her urinalysis does show that she has nitrites, some bacteria, some clumps of WBCs, but again, no urinary symptoms. Her white blood cell count is normal at 9.27, but her platelets are a little bit low at 88. Now, because of her history of IV drug use, the clinician astutely says, gosh, this could be a spinal epidural abscess. And she actually does, in the chart, it's documented that she does have tenderness in the lumbar region, L1 through L3, somewhere in that region. The clinician gets an ESR, it's elevated, and so says, this could be spinal epidural abscess. Let's go the next step and get an MRI. The clinician gets an MRI of the entire spine because there are instances where there can be skip lesions, not just spinal epidural abscess in the lumbar region, but in several other areas. But the MRI doesn't show any acute process. And so what happens next, this entire process, as you can imagine, takes several hours to get the MRI from the emergency department after all these other tests are back. And now the clinician is they're scratching their head a little bit to say, okay, she has severe back pain and elevated ESR, a history of IV drug abuse. Let me talk with neurosurgery about this case. So the clinician talks with neurosurgery. They come up with a plan that says, well, her MRI is negative for spinal epidural abscess. How about we see her in the office in 2 days? She can follow up with us, and we'll see what's going on, what could be the cause of the back pain. They work through getting a discharge plan set for her and are all set for her to be discharged home. But a couple things are key as we look through the timeline of this case. So she's there for about 8 hours in total, with several different things being given to her, IV fluids, pain medication multiple times. And one thing that is not addressed anywhere is her persistent tachycardia. She is persistently tachycardic from the moment she enters the emergency department till the very last one that's documented. The lowest documented heart rate at any time is 102, but multiple times she's much higher than that. So the plan is for her to follow up with neurosurgery. She gets discharged, although she really has significant back pain, and so they have to help her out in a wheelchair. So what happens next? Unfortunately, she goes home. She has a very complicated next 72 hours. She actually becomes altered, becomes febrile, and is taken to another facility where she's diagnosed with acute renal failure, floridly septic, actually from an MRSA, urinary tract infection. Unfortunately, she dies 48 hours later. We have a 21-year-old mother of two who's now dead. And the allegations in this case were many. But one of the things I really want to focus in on is what could have clued us in more. She had no urinary symptoms, but is there something else that there might have been underlying that could have helped clue us in? And the tachycardia is really key in this case. While many of the other vital signs can be picked up on history and physical exam, right? So we can see if someone is tachypnic. We can feel if someone feels warm. We can repeat some of those tests, especially if there was a spurious blood pressure. We can identify those, but tachycardia really can slip past us. We can be talking with a patient and believe that everything is okay without recognizing that they have a heart rate of 115 or 120 or 125. And that's a real clue for us that there could be something else going on. I wanted to share, this is a paper that came out in 2019 about some data regarding abnormal vital signs. So as in the name, they are vital. But it's oftentimes overlooked, especially when we are getting ready to discharge someone. We say, they look good now, the rest of their tests came back negative, but what does it mean if they had abnormal vital signs? This was a study where they took close to 1 million patients and said, of those individuals who have bad outcomes, what's the relationship with a bad outcome and abnormal vital signs? And by bad outcome, I mean dying within 15 days after their emergency department visit. They took those cases where they had a bad outcome and matched them with controls. They had about 300 in each group. And what did they find? Having any abnormal vital sign increased your odds of dying within the next 15 days with an odds ratio of 3.06. Specifically though, heart rate is very key in that. Again, some of the other ones we can identify, patients who are hypotensive, who are tachypnic, who are hypoxic. Tachycardia though can slip past us and can be an early sign of evolving sepsis. For every increase beat from heart rate over 100, the odds of dying in the next 15 days increases, 1.04. So a 4% increase for every one beat as your heart rate increases. That's really key for us to keep in mind as we consider tachycardia as a warning sign that something else more serious may be happening. Now that's one paper. There are multiple other papers out there, and without going into each one of them, the totality of the evidence really suggests that tachycardia, especially at discharge, is really a key predictor of individuals who are going to have poor outcomes, either return visits with admission to the ICU or death after emergency department visits. And so that's why it's really important for us in the ED, especially for an early signs of sepsis, is to fear abnormal vital signs. And I mean that in terms of an acronym. For fear, from vital sign standpoint, we need to do one of a couple things, and maybe even multiple things to address these. The first is to try to fix the abnormal vital sign. If someone's tachycardic, what can you do to fix that? Do they need fluids? Is it due to pain and they need pain medication for it? Doing something to fix those abnormal vital signs before the patient goes home is really key. E stands for explain. So why do you believe they're tachycardic? Is it due to pain? And if so, mention that. Is it due to, let's take for example, a patient with an asthma exacerbation who's getting beta agonists, they're getting albuterol. Well, you may explain in your note that they're tachycardic because of the albuterol, but explain why you believe they're tachycardic. That ties in a little bit to the A, which is to address. Many times, patients are discharged home without documentation or recognition in the clinician's note about the tachycardia that they had. And so calling it out in your medical decision making, that ties back into explaining why you believe it, but specifically calling that out that you recognize they were tachycardic. The last is to recheck. And the number of cases where a patient presents is tachycardic in the triage area and their heart rate is never reevaluated, that's a real challenge to defend that. And so doing a recheck, reevaluating and documenting a repeat heart rate is really critical. Many times there may be patients who come in who are initially tachycardic in triage. They may have just walked in from the car or some other scenario, and rechecking them identifies that their heart rate is now in the 70s, 80s, 90s. But if there's not a recheck, it's very challenging to identify where they're going with their heart rate. And again, tachycardia can be a key indicator of an underlying serious condition. So the take-home message for this case and for patients in general is to fear tachycardia at discharge. Doesn't mean to be afraid of it, but it means to fix, explain, address, and reevaluate. Next thing is something if you're doing is I would like you to stop doing. And this is a real case. We've actually had identified several of these. I'm going to take this example. This is, again, a real case that went to litigation with multiple different issues that were identified, but I want to focus in on just a couple for now. This was a 69-year-old gentleman. He had a history of C. diff colitis, along with some other medical conditions, high blood pressure, diabetes, hypercholesterolemia. He presented to the emergency department with abdominal pain and diarrhea. He got a workup including a CBC, BMP, and actually had one imaging test performed in the emergency department. Now, his workup did show that his white blood cell count was elevated. It was 24.4. And the clinician felt, gosh, this patient's had C. diff colitis multiple times before. The abdominal pain seems similar to that. And I would like to talk with his infectious disease specialist. So this provider talked with ID on call, talked with them through the lab results, and they decided together that they would like to put this patient on IV flagyl, and he got admitted to the hospital. Now, I mentioned that there was one test that was performed, one imaging test that was performed in the emergency department. So in this individual with abdominal pain, with diarrhea, with a history of C. diff colitis, there was concern for, could there be other complications? Toxic megacolon or bowel obstruction, and one imaging test was performed, and that was an abdominal flat plate. There were read as air fluid levels on that x-ray, and that's where the diagnostic imaging stopped, was at an abdominal x-ray. The patient was started on IV antibiotics, admitted to the hospital, IV flagyl specifically for potential C. diff colitis, and this is where, unfortunately, the patient has a bad outcome. So over the next 8 hours on the floor, the patient decompensates. He went to the intensive care units where he was aggressively resuscitated, given IV fluids, broader spectrum antibiotics, unfortunately died about 3 hours later. The concern when this went to litigation was for under-resuscitation and under-recognition, and failure to recognize, development of intra-abdominal sepsis. And while C. diff was certainly a concern, there are multiple other potential causes for intra-abdominal sepsis that can be missed specifically with an abdominal x-ray. So let's look at that just a little bit. And if we step back and examine x-rays in terms of low severity illness all the way up to high severity illness, let's first look at why many clinicians will get an abdominal x-ray, and that's often to look for constipation. This was a study performed that was published in 2020 where the authors looked at patients who had an abdominal x-ray to look for constipation, right? So on the milder end of the disease processes that we may get an x-ray to look at. And they wanted to see how often the radiologist's interpretation of the volume of stool in the colon actually correlated with what the clinician ultimately decided and treated the patient for. So they broke the x-ray interpretations into two groups, a moderate to large amount of stool or none to very mild amount of stool. and then said, what did the clinician ultimately end up doing for the patient? And of those who had moderate to large amounts of stool, as read by the radiologist, more than half of them did not receive any treatment for constipation or a diagnosis of it. Now, on the flip side, of those close to 200 cases where there was minimal stool in the colon, more than half of those were ultimately diagnosed with constipation and treated for it. So there's a disconnect between the interpretation on the x-ray and what we actually do. The diagnosis of constipation is a clinical diagnosis, not one that we need a radiograph for. Now let's move to something else more further along on the spectrum of severity, and that's appendicitis. This is one of the major causes of missed causes of abdominal pain that go to litigation. And so what these authors did is they said, let's look at predictors for missed appendicitis. And they took over 100,000 patients. This is from an insurance database, and broke them into adults and children. About 6% of adults had a missed appendicitis, so they had an emergency department visit and then came back within the next few days and were ultimately diagnosed with appendicitis. Little over 4% of children had missed appendicitis. Interestingly, of those adults and children with missed appendicitis, a significant portion had only an abdominal x-ray performed on their initial emergency department visit. And so when the authors looked at factors that were associated with missed appendicitis, they identified a few different factors. First was a diagnosis of constipation. So the adjusted odds ratio in adults was 1.51. In kids, it was 2.43. So a diagnosis of constipation was actually associated with higher odds of missing appendicitis. Another condition was adults with comorbidities. Adults with several other medical conditions may make it a little more challenging to tease out that it's appendicitis, and so those individuals also were at higher odds of missed appendicitis. But the last thing, which is really interesting and key to what we're talking about here from an imaging standpoint, is obtaining an abdominal x-ray was associated with increased odds of missing appendicitis. And that is related to no testing. So if we take patients who got no imaging, no x-ray, no CAT scan, anything, and compared those who got just an abdominal x-ray, those who got an x-ray were actually at higher odds for missed appendicitis than those patients who got nothing, no imaging test. So it's really important for us to consider that abdominal x-rays for low severity illness, constipation for example, those often don't align with what the diagnosis we make clinically, and constipation is a clinical diagnosis. And as we move up the spectrum of disease to appendicitis and even other conditions, diverticulitis, mesenteric ischemia, all sorts of other conditions, X-ray is really a poor test for being able to identify those conditions. And so the take-home message from this case, and several others like it that we've seen, is do not routinely get abdominal X-rays in patients with abdominal pain. The third case that we can take something home from is a patient-related, a condition related to a patient with kidney stones. And in this last case, we're going to pick out a few elements from this, but we've actually identified several cases that have these similar characteristics. So I hope that this will be able to give you some useful information to be able to take the next time you're seeing someone with a kidney stone. This is a 67-year-old female who came in with right flank pain. She's had multiple kidney stones before and says, "Doc, this feels just like the kidney stones I've had before. Yep, it's here on the right side. I've had them many times before." So even from the triage area, the doc, the nurse, everyone saying, "Yep, this seems like a kidney stone." Her vital signs are listed there. Temperature 99.9, so not quite febrile, but she's hinting at it. Heart rate is 79, respiratory rate 18. Her blood pressure is a little bit on the soft side, especially for a 67-year-old female, 100/57, and she's 98% on room air. She does get a workup that includes a urinalysis and a CAT scan. No blood work, but a urinalysis and a CAT scan. And the CAT scan shows a right-sided hydronephrosis with a distal ureteral calculus, 2.6 millimeters, so small kidney stone, but it is there. Her urinalysis shows WBCs and a few bacteria, but no nitrites and no leukocyte esterase. So in working her up, they do give her pain medication. She feels much better after that. The Clinician says, all right, you've had many of these before, let me talk with your urologist about this. So they put a phone call out to the urologist, talk through everything with them. The urologist says, yep, appreciate the call. She does have a kidney stone. I'm not too concerned about the WBCs. She can follow up with us in the next week or so, and let's get her into the office and we'll follow her up for this 2.6 millimeter kidney stone. So she's discharged, and the clinician goes about their business. Unfortunately, though, over the next 2 days, the patient decompensates. She ultimately comes back to the hospital 2 days later because of altered mental status. At this time, she's hypotensive, she's tachycardic, she's febrile, she's in acute renal failure, fulminant sepsis from an infected kidney stone. She gets admitted to the hospital, and even with resuscitation with IV fluids and antibiotics, she dies 24 hours later. So this case went to litigation, and one of the concerns for this, and one of the things that we can potentially take away is, could there have been something else done differently to potentially identify an infection that could have led to her ultimate outcome? And could something else have been done differently at that initial visit? So let's talk first about what she had as far as the urinalysis, because for her vital signs, she was not febrile, although she was close. She was not tachycardic. Her blood pressure was a little bit on the soft side, but not necessarily hypotensive. And we have a CT scan, which shows an obstructive stone, 2.6 millimeters, and a urinalysis that shows WBCs and bacteria, but not a couple of the other elements that we might think about on a urinalysis as indicating signs of an infection. And so one of the things that's really key for us to consider with urinalysis and kidney stones, and specifically when we're looking for infections, is what I call the rule of tens. And what that is about 10% of kidney stones are infected. So you think of the volume, the number of cases we see day in and day out where someone has a kidney stone, 1 in 10 of those will be infected. And so we need to look for those. Now, we'd love it if our urinalysis was 100% sensitive and 100% specific. Unfortunately, we don't have any tests that really is that good when we're talking about identifying infection in the urinary system, in the collecting system. And we have to understand the limitations of urinalysis. So it can be negative in up to 10% of cases, meaning we may not see signs of clear infection with WBCs, bacteria, nitrites, and leukocyte esterase. We may not see all of those elements, but a patient may still have a urinary tract infection. So it's incumbent on us to have a high index of suspicion and really look a little bit more deeply in some cases for a potential infection. That could involve an expanded testing regimen, including a potential CBC and lactic acid. Doesn't mean that those are 100% perfect either, but it may help to provide a more clearer picture if the patient has evolving sepsis physiology. The last of the tens is if the WBC in the urine is greater than or equal to 10, really consider the potential for infection. While sometimes a urinalysis can show WBCs if there's other inflammation, WBCs of 10 or greater may indicate that the patient has an underlying infection that could require antibiotics. May not necessarily always require admission, but could potentially benefit from antibiotics in those patients who otherwise look well and might be going home with a small stone. Those individuals may benefit from oral antibiotics if the decision is made to go home, but they should be followed closely by urology. So let's look just back for a minute here. Our 67-year-old female who came in with right flank pain, she's had multiple kidney stones before, and one of the things on the urinalysis that is really concerning is the volume of white blood cells. So that's over 10. So our rule of 10, that 10% of kidney stones can be infected, 10% of the time the urinalysis is normal, even when there is other pathology going on, and that if the WBC is over 10, even if they look otherwise well, they may warrant antibiotics if they're going home. Consider that in those patients. So the rule of 10 is really important when we have patients with kidney stones. And so having a low threshold to treat, especially if there's concern for potential infection when the WBCs in the urine are greater than or equal to 10.